identify the risk factor and minimize the risk factors. Once the staff know about the risk factor, somebody admitted with like elderly admitted to the hospital in ICU, they are mechanically ventilated. So if the staff is aware, they are more prone to like minimize the risk factors, and they're more prone to easily diagnose it. For diagnosis of delirium, it is very important to monitor ICU delirium by using CAM-ICU, which is confusion assessment method for ICU. This is a sort of tool. So every time or every shift, every nursing shift, it is recommended by the professional bodies of critical care that it should be monitored and document whether somebody is already encountered with the ICU delirium or somebody more prone to. So if it is monitored every shift, it is very easy to detect at the same time and then treat promptly. As I said, patient negative poor outcomes can be prevented if delirium is assessed and monitored routinely, dealt and treated promptly, and it is very difficult to treat delirium if left unrecognized. That is why nurses' role to detect and manage ICU delirium is very, very important. ICU nurses' role is vital due to their frontline position. ICU delirium remains grossly unrecognized in hospitalized patients. This is like number of evidence I have searched and different articles and research I have go through. It is revealed that the ICU delirium is remain unrecognized, and there is no assessment tool in place to monitor ICU delirium. One of the authors suggested, after doing the research, like only 40% of nurses monitor delirium and 16% of nurses indicate using an assessment tool, and only 7% have used a valid tool. Nurses have done a superficial mental status assessment and have overlooked important clinical features of delirium. This is one of the authors just reported. Just to sum up the session up till now, delirium is most common and dangerous disease in critically ill patients. It is more common in elderly, post-operative and medical cases that are on mechanical ventilation, especially with the history of cognitive impairment such as dementia. The complications of delirium have manifold, such as an independent predictor of increased mortality, prolonged mechanical ventilation, prolonged length of stay in ICU and hospital. So it is all cause affected as well. The weight of evidence has strongly suggested to monitor ICU delirium by using CAM-ICU as a standard practice. UK government has introduced a number of policy drivers, which I have just discussed with you, to safeguard patients and standard of practice, and has encouraged nurses to participate in transformation of practice to enhance evidence-based practice and safeguard patients. This is the one I've went through all the literature search after doing all this, and then I decided to do. At my workplace, there was no CAM-ICU in place in ICU, and there is no ICU delirium monitoring going on. That's why I've decided to implement a project at the workplace. The aims and objectives I've made after searching all the evidence, that to implement a nurse-led confusion assessment method for ICU, an assessment tool to assess or monitor ICU delirium in a general adult ICU. The objectives were to enhance patient safety and prevent from harm, to assess and diagnose ICU delirium promptly, to prevent complications of ICU delirium, to reduce the cost of care with regards to ICU delirium, to equip staff with required skills to use CAM-ICU and monitor ICU delirium. Because what we have identified, the staff was not aware about the risk factors of ICU delirium and the prevalence rate of the ICU delirium and how to use CAME ICU. That is why one of the objectives says to equip staff with required skills to use CAME ICU, to transform practice in order to promote evidence-based practice. Now, what is practice development and why it is necessary? I'm not going into more detail. I'm just going through briefly. UK government policy to transform practice to improve patients' care. Like UK government introduced so many papers time to time, and then all the initiatives appear to be failing. This is what one of the authors pointed out. This is how UK government has been led to go to practice development concept. The purpose of the practice development is to promote person-centered and evidence-based practice and level of the care. The level of care is, like in practice development is from top to bottom. Like the practice development is done at the level where the care is given and taken, but it is well facilitated from the top management. So it is both ways basically. Learning incorporates a formal system of active and work-based learning to transform practice. It enables nurses to develop personal and tacit knowledge by reflecting on their own work experience as well as team. And similarly, we use the evidence, whatever evidence is available, we use the evidence to do practice development. At the same time, once the practice development is done, we generate some evidence as well. So it's both ways again. Creativity, it incorporates creativity and enabling clinicians to think freely, to use and enhance their critical thinking for the betterment of patient care. And it uses, like variety of methodology and methods. Now I come to the point where we, I used change management project. Something about the change. Change is challenging for change agents or nurse leaders in a complex healthcare organization which has a vertical management structure. Like the management structure is quite vertical, that is not like horizontal, that okay, manager is like sitting next to you and you can communicate easily. So it's very, very challenging because it's quite vertical management structure in NHS. Change is defined as a dynamic process by which an alteration is brought about that makes a distinct difference. Change agents are those people who bring the ideas for a goal-directed change and drive the change process stage by stage. And this is, again, it's all planned change because we don't want any haphazards and change just occurs, which is not going to be sustained. The context of nurse-led change is already important as well, because what UK government wants to use a bottom-up approach to, because the nurses are in frontline state and they identify the patient's problem every day. So this is what UK government's committed to promote this approach, to empower nurses as well. This is force field analysis. Before we going to implement a change management project, we need to use a force field analysis. The concept is all about the forces are working in a field, and the forces are maintaining equilibrium or status quo, and it is very important to disturb the status quo to bring the change in, and this analysis identify the restraining forces and driving forces, the forces which can be helpful to use in change process, and some forces you identify as a restraining forces, like they can be uh, they can be they can be they can be an obstacles in like in change process. So this is how we need to find out the both type of forces, and then we see that like which forces can help and which can be an obstacles. So when I did when I did the force field analysis, the driving forces were quite like high, or number of the driving forces were like quite high than restraining forces. The driving forces I identified, like available evidence regarding delirium and KMICU, which is already like there's a pile of literature and the research about KMICU and delirium. Government policy drivers, which I have just mentioned before, supported by management, ICU consultant and senior nurses and the leaders. These are the like driving forces as well. When I discuss with them, they all ensured me to like to take a part on that. Mentored by practice-based educator. Because it has to be a mentor who can like help process and coaching the process to be successful. So I selected practice-based educator, which was already like an effective clinical leader. No cost associated with change in practice. There was no cost associated, so that was easy to implement. Re-education, training, opportunities for staff, professional development. Staff was like bit worried how they can use KMICU once they are not aware of. So we just use this point as a driving force. We reassured them all the re-education and training opportunities will be encountered in the future, how to learn, and that will be a personal development and professional development for them. The restraining forces, because I am a junior staff and leading change, I am band 5, I am not in band 6 or band 7. That was just sort of restraining forces, because what literature says, it mostly comes from the nurse leaders. So that was one restraining force. And to